Okay, we are live in 3, 2, 1. So, good morning, everybody, and wishing you all a happy Teachers' Day from IOA TV and Ortho TV. For further proceedings, I'll hand it over to Dr. Ajit. Over to you, sir.
Good morning. Can I start?
Yes, please, sir.
Good morning to all the viewers and speakers of this webinar. Myself, Dr. Ajithkumar, MN, Chairman, Pelviacetabular Subcommittee of Indian Orthopaedic Association. This is our second webinar we are conducting along with the Association of Pelviacetabular Surgeons of India. Our first webinar was about the pelvic fractures, and today's webinar we will cover topics about acetabular fractures, basics and approaches. We will be talks and discussions about this topic. We have got 6 eminent faculties from various parts of India. And now for the welcome address, I invite Honorable Secretary of IOA, Dr. Naveen Thakkar, sir.
Yes, Dr. Ramesh Sen is here, sir, as the President-elect. So I think he will address first, then I will address. Ramesh Sen, sir, please.
Okay, then I'll invite Ramesh Sen, sir.
Yes. That is
Thank
the
you for the opportunity. I definitely looking at pelviacetabular trauma, and I'm very happy.
Ramesh Sen, sir, please.
Yeah. Am I audible? I think.
Yeah, you're audible, sir. You're audible.
Yeah. So I was just saying about it that I'm happy to see that pelviacetabular trauma has been now in the syllabi of Indian Orthopaedic Association, because for many years, in the last 10-15 years, we have been looking for some pelviacetabular talks in IOA. So we did have opportunities to have workshops. We did have all those things. But to be as a part of the main curriculum, to be given a specific days, I think I'm quite happy with the Indian Orthopaedic Association decision, Dr. Shiva's decision to get this into this picture. And I'm sure that our AOPAS will bring it into a right perspective of actually training our orthopedic surgeons to this specialty, which in the past has been a neglected area for most of the senior people. Had just one thing, give traction and rest with that. And now we are able to know what it is. Now we are able to appreciate the complexities of this thing and the peculiarities of this thing. And I feel very happy when some trauma surgeons do write it out as pelviacetabular surgeons along with it. So that gives a kind of a distinct name, nomenclature to the position of being able to operate upon. I'm sure all our these senior faculty members are enabling our colleagues all around in this field. All my best wishes for this IOA Pathshala, which is the second part of it. And I'm sure all people will be able to gain and get benefit. All my best wishes. Thank you.
Dr. Naveen Sekhar, sir.
Okay. So to inform you, we have already circulated this by email, all the links of the pelviacetabular, and 3,000 people have opened up the mail first time in the IOA for pelviacetabular program. So today you are going to get a good count probably in this program, because 3,000 is the open rate of the mail, which is not routine. So it's a very good focus to the general orthopedic surgeons, and I am thankful to all the faculty that they focus basics and create the interest in general orthopedic surgeon for this. We have to make a platform for all subspecialty and academic activities, so that we are doing. And we are really thankful to AOPAS and all the faculty for having their valuable time and their thinking and their sharing and contributing to the academics. Thank you very much. Now you can proceed with your academic program. Thank you very much.
1 minute, sir. Now I can invite Dr. Ragesh Rajput, sir, President, Association of Pelviacetabular Surgeons of India.
I think he was out of somewhere. That was the message. He's there?
Okay, then I will invite Dr. Pranav Shah for the introduction of faculties and moderating the webinar.
Yeah, good morning, everybody, and happy Teachers' Day to all. Happy Teachers' Day to the people whom I'm seeing in my screen. They have been teachers for us, and it is a proud privilege for me to welcome the distinguished faculty All of them are AOPAS faculties also, and they are our colleagues, our friends, our guides. So first, I would welcome Dr. Pradeep Kothadia, sir. He is from Solapur. He is the past president of Association of Pelviacetabular Surgeons. Then I would welcome Dr. C.P. Das, sir. He is from Bhubaneshwar, and he has also been a past president of the Association of Pelviacetabular Surgeons. I would welcome Dr. Sameer Agrawal. He is from PGI Chandigarh, a very distinguished faculty in the Association of Pelviacetabular Surgeons. I welcome Dr. Jose Papancherry. He is from Cochin, and he is also a president-elect of Association of Pelviacetabular Surgeons. And apart from that, I welcome Dr. Ramesh Perumal from Coimbatore, a very well-renowned trauma surgeon, pelviacetabular surgeon, and Dr. Lokesh V from Bangalore, who is also a very well-renowned pelviacetabular surgeon. I hand over to Dr. Ajithkumar to take forward the proceedings. Since I'm traveling, I may not be able to be with you all along, but I will try to maintain as best as I can. Thank you.
So now I will invite Dr. Pradeep Kothadia from Solapur for his lecture, How to Diagnose and Classify Basic Acetabular Fractures on X-rays.
Good morning, everybody. I sincerely thank the Indian Orthopaedic Association and AOPAS to include me as a part of this scientific program. Dear friends, we know this fracture is a complex fracture, and for treatment, we have to classify this fracture. So today, I'm going to tell you how to diagnose and classify a basic acetabular fractures on X-rays. I'm going to show it with the help of X-rays as well as with the bone model to make things a little bit simplified. So to understand the radiological classification, we must know the basic applied anatomy of acetabulum, that too a column concept, an anterior column and a posterior column. Column concept, what are the parts? It's very confusing. So which is anterior column, which is posterior column, a little bit confusing. To me, to make it simple, I just look at the X-ray of a pediatric age group. You get a tri-radiate cartilage with the help of ilium. Bones which are contributed is ilium, ischium, and pubis. To me, whatever is developed by ilium and pubis is the anterior column. Whatever develops with the ischium is a posterior column. It's so simple to just recognize what part is anterior column, what part is the posterior column. Now, to know about the normal radiology first, and then we'll go on to the subsequently with how to read these X-rays for diagnosis of the fractures. The normal radiology is a plain X-rays which consist of a standard AP view, geodate views, which are also required to just go into the details of the fractures geometry. It's an iliac obturator view and it's an obturator oblique view. This, with the help of these three views, almost 95% of the fractures can be classified very well and can be treated using this. Yes, nowadays in our armamentarium, we got advanced radiologists like CT scan, 3D plastics models, even as MRI is included in nowadays when you are diagnosing the fractures in pediatric age groups. So today I'm going to concentrate more on the radiology of these fractures, how to read them. Now, to read these X-rays, we must know the interpretation of these X-rays depends upon the knowledge of the normal radiographic lines. And disruption of one of this line is represents the fracture of that part of the bone. This is a plain X-ray of a pelvis with both hips. We will see the lines gradually one by one. First line we see is an iliopectineal line, which shows us what's happening with the anterior column. The second line is a major line, which is the ilio-ischial line, which starts from the ischium, goes up to the greater sciatic notch, which shows what's happening with the posterior column. We see the medial wall or a teardrop, which gives some information regarding the quadrilateral plate of the acetabulum. Then the next thing is a sourcil, the weight-bearing portion of the dome of the acetabulum, which is the most important part to reconstruct. Not even a 1 millimeter gap is accepted in this area. The walls we have to see anteriorly, anterior wall, which starts from the inferior aspect of the superior pubic ramus goes into the lateral part of the acetabulum, and the posteriorly, starting from the ischium going to lateral part of the, these are the two lips. So with the help of these 6 lines, we will be able to classify these fractures. Now we'll see obturator foramen is one of the part which is also important to classify these fractures. The spatial views, obturator oblique view, where you have to take the X-ray in 45 degrees of interrotation. What you see in the obturator view, we see the obturator foramen very well in this obturator view. The iliopectineal line is anterior column. We see the anterior column very well in the obturator oblique view, and we see the posterior wall of the acetabulum. In this also, we can see whether the fracture dislocation is there or whether there is a fracture subluxation of the hip, also very well seen in this view. The next view we see is a ilia oblique view, exactly opposite of the obturator oblique view. It is 45 degrees externalization of the injured lip, and take an X-ray. What do you see in that? We see a greater sciatic notch. We see very well the lesser sciatic notch. We see the ilioischial line very well. We see the whole of the iliac wing completely very well in this. We can get all the fractures of the ilium in this area. And here we see the posterior column very well completely. We see the anterior wall. So with these 3 views, as I told you, we can cover almost the 95% of the fractures. With the understanding of this normal radiology, all these lines, we now will go ahead with the fracture classification of all the elementary fractures. Classification, which is given to us, is by Luternal and Duret. The classification is based on the force of direction. There is third group, AO group, which has got a comprehensive classification. But all over the world, people still uses Luternal's and Duret's classification. How this person classifies the fracture, Luternal Duret? We get elementary fractures. So I'm going to talk today with the elementary fractures, and there are associated fractures. A little confusing. To make it a little bit simple, I just always say a single axis fractures, either a vertical or horizontal, are elementary fractures. When both the axes are there, it is a associated fractures. So now today I'm going to talk a single axis fractures. Acetabulum gets divided by a vertical axis into 2 parts. It's a single axis. This axis, when it goes posteriorly, you get a posterior column. When this axis goes anteriorly, it's anterior column fractures. It is that simple. All these elementary fractures are classified in a vertical axis. The horizontal axis is a fracture which goes into horizontal axis, which takes away the 2 parts of the acetabulum. Ilium is different. Ilio-ischium and pubis is different. The transverse axis may be at different levels, and accordingly, the types of transverse fractures are given. So, dear friends, we are going to see today posterior wall, posterior column, anterior wall, anterior column, and a transverse fractures. These are all fractures in vertical axis. This is in the transverse axis. Now, we'll see how to diagnose these fractures from the X-rays one by one. We'll concentrate now first on posterior wall and posterior column fractures and how to diagnose on the X-rays. Very well, these fractures are seen in AP and obturator views. So this is, see this iliopectineal line. Now there's going to be a lot of repetition of the lines. We have to see these lines regularly. So it's an iliopectineal line. There is no break in this line. So anterior column is good. Ilioischial line, there is no break in this line. So your posterior column is good. This is an anterior wall line. Seems to be very good. So there is nothing in the anterior wall. Then ideally the posterior line should be in this direction, but here you see the posterior is not in the same direction. It is some deficiency in the posterior line. There is a fragment of the wall. So where is that fragment? This fragment is on the top of the head of the femur. You can see also very well in this obturator oblique view, the iliopectineal line, very good. The anterior, the posterior wall should have been like this, but this is the posterior wall line, and this wall fragment is on the top of the head of the femur. You can very well see the subluxation of the head of the femur. So this is a bony model diagrammatic presentation of the posterior wall fragments. The posterior wall gets detached from the acetabulum posteriorly, and you can get a subluxation or dislocation of the head of the femur. The posterior wall, what do you see? Intact iliopectineal line. Just to repeat everything, recollect intact ilioischial line. intact wall line, anterior wall line, but broken posterior wall line. And you see the fracture wall fragment, which is on the top of the head of the femur. Next, how to see a posterior column on routine X-rays? We'll see the same lines again. You can see both the views, a AP view, and on your right, it is an obturator oblique view. I'm going to show both at the same time. It's the iliopectineal line, which is intact. There is no break in that line. See the ilioischial line. There is a break in the ilioischial line. You can see the fragments, the lines which are broken. So definitely there is a fracture of the posterior column which is seen. Okay. See the obturator foramen. In the obturator foramen, you see there is a break in the obturator foramen. So this fracture of the posterior column, either it breaks at the inferior ischio-pelvic ramus, or it gets gets rotated at the symphysis. The whole column gets displaced and the head is medialized in this patient. This is a fracture of the posterior column. So the whole fracture which is seen in this bone model is a posterior column fractures. So in posterior column, what do you see? An intact iliopectineal line, a broken ilioischial line, a fracture of the ischio-pelvic ramus, or symphysis disruption. These are the things which are classical seen for the posterior column. Now we'll move on to the anterior column and anterior wall fractures. We have to see all the three views for this. This is the anterior wall. Again, I'm going to talk to you regarding the lines. Iliopectineal line is absolutely not broken. Ilioischial line is good. The posterior wall line is very good, but the anterior wall line has to be in this direction, but it is like this. So this piece of the anterior wall is on the head of the femur, and there is a subluxation or dislocation of the head of the femur, which is out of the socket. So this is a bone model representation of the anterior wall, which gets fractured, and the head also gets subluxated with that. Anterior wall, what do you see? Intact iliopectineal, intact ilioischial line, intact posterior wall line, intact obturatory, but broken anterior wall line with a piece which is seen on the wall fragment, which is seen very well. So this is just to recapitulate everything about the anterior column. We'll go on to the anterior column fractures. Here, the iliopectineal line is broken completely. It is distorted completely. Second thing, the ilioischial line seems to be very good. There is no breakage in the ilioischial line. The posterior column is good. You see the break in the inferior ischio-pelvic ramus. So this is a anterior column fractures where you get all the anterior column getting rotated at this axis from the iliac crest to the inferior ischio-pelvic ramus. And the head, you get a very well picture of this anterior column fracture. This is iliopectineal line, which is broken. This you can see in iliac oblique view, the fracture line going right up to the top of the iliac crest. So these are the all anterior column fractures. You see, this is the bone representation how the anterior column fracture is seen with this. Now, in anterior column, again, to recapitulate everything, we get a broken iliopectineal line, intact ilioischial line, obturator ring is also broken in this, intact wall lines. Now, in anterior column, there are three different types depending upon the level of the fracture. Either they are low, intermediate, or high. How to differentiate? There are three types. Low, see the fracture line here is going below the anterior inferior iliac spine. If the fracture line is going below the anterior inferior iliac spine, it is a low fracture. If it is in between the anterior superior iliac spine and anterior inferior spine, it is intermediate fracture line. If it is going high up to the iliac crest above the anterior superior iliac spine, it is a high variety of anterior column fractures. This is again just to give some information the bone model. This is between high anterior column, between anterior superior iliac spine, anterior inferior iliac spine. This is between a fracture line between the anterior superior iliac spine and anterior inferior iliac spine. And this fracture line is above the highest point of iliac crest, or it is above the anterior superior iliac spine. Now, the next fracture, elementary fracture, is in the horizontal axis. It is the transverse fractures. We see the AP view, we have to see the oblique view, and we have to see both oblique views for that. In AP view, this is the fracture line. What do we see? The iliopectineal line is broken. The ilioischial line is also broken. See the obturator foramen, it is not broken. The wall lines are absolutely okay, nothing. So this is a transverse fracture where you get two lines, major lines are broken. Iliopectineal and ilio-ischial lines are broken. Remaining things are absolutely intact. What you see in the iliac view, see the fracture line, we can see the fracture line extending into the posterior column. Ilio-ischial line is broken in this. The wall line absolutely okay, anterior wall line is okay. In obturator oblique view, we see the fracture line extending onto the anterior column where the iliopectineal line is also broken. The obturator ring is very well seen in obturator oblique where it is intact. So this is a classical example of a transverse fracture. The posterior wall is absolutely very good. So this transverse fracture is a diagram, it's a bone marrow representation where you get axis differently, where the iliac segment is different and ischio-pelvic segment is different. Now these transverse fractures, to recapitulate, what we get? A broken iliopectineal line, a broken ilio-ischial line, intact obturator foramen, and intact both the wall lines. So only the two lines are broken, which is a classical example. With a intact obturator foramen, you get a transverse fracture. There are three types of, again, transverse fracture depending upon the level of the fracture. They might be transtectal, juxtatectal, or infratectal. These three types. See, this is a transtectal, which is the fracture line extending up to the dome of the diaphragm, which is very important to treat these fractures absolutely normal anatomically. Second is a juxtatectal, which is through the condyloid fossa. A lower portion of the condyloid fossa is an infratectal. This is in the lower portion of the condylar fossa. So these are the three types of the transverse fracture: transtectal, juxtatectal, and infratectal. Just to make it simplified, this is a transtectal fracture. You can see the fracture occurring at this level. Juxtatectal fracture, which is occurring in the condylar fossa, just below. And the third is infratectal fracture, which is going either lower portion of the condylar fossa or below the condylar fossa. Infratectal fractures can be treated conservatively with that. Now, dear friends, just to summarize all the elementary fractures, I have made an algorithm for classification of these fractures. There are two important lines we have to see. One, iliopectineal line. We get, if it is broken, you get an anterior column. And there are varieties of the anterior column fracture, types of anterior column fracture, depending upon the fracture line, a low, intermediate, and high between the ASIS and AISS. Now, if it is not broken, C for the wall line. If the wall line is broken, it is an anterior wall fracture, which has to be confirmed in other views. Ilio-ischial line, again, if it is broken, it is a posterior column fracture. If it is not broken, C for the wall line, and you get a, if it is broken, you get a posterior wall, may be associated with either subluxation or dislocation of the hip, which is seen very well into the obturator oblique view. If both lines are broken, then you have to see for the obturator foramen. If the obturator foramen is not broken, then you get transverse fracture. And we get three types of transverse fracture depending upon the level of the fracture: transtectal, juxtatectal, and infratectal. So this is an algorithm just to classify elementary fracture with the help of this algorithm. Thanks. Thank you for your patience list. Thank you.
Thank you.
Dr. Kothadia, sir. It was a fantastic lecture, fantastic summary. The last algorithm was absolutely perfect. It is so easy now for us to identify the fracture patterns. And this is exactly what I had asked him to do, and he has done it perfect. Thank you, sir, very much.
Thank you. Thank you, Pranav.
Yeah. Dr. Ajithkumar, do we take questions now or do we take the questions later?
So we'll go on to next topic.
Fine. May I please invite Dr. Ramesh Perumal? Dr. Perumal is going to now help us in decision making. We already have identified the fracture on the X-ray. Now what next is to be done? That Dr. Ramesh will tell us.
So good morning to all of you. So it has been a wonderful day. Today is a happy Teachers Day. So all of you are my teachers. And a special thanks to Dr. Ramesh Sen, because I have learned like a guru disciple. I have learned from hand-to-hand experience from 2012 onwards. My sincere thanks to all of you. And very good morning, and thanks to IOA and Association of Pelviacetabular Surgeons of India for giving me the opportunity. It was well evaluated talk by Dr. Pradeep Kothadia, sir. Now I move on to the evaluation of CT scans and decision making in acetabular fractures. So this is a 41-year-old male who had sustained a road traffic accident. You would have seen there is a dislocation of left hip, and there is a small fragment is seen in the posterior side. All of you will accept this treatment would be a close reduction in these injuries. And further, if you carefully look into the joint line, the joint is congruent, but there is small amount of fragment is seen. Probably the attitude was a posterior dislocation, so that it might be a posterior wall fragment. So next course of action would be taking Judet views. So now you see the posterior wall fragment is very well seen in update review. You can see it in the update review. And the iliac view is normal because the other lines are intact. All of you will accept the next course of action would be to take a CT scan. So reading a CT scan is very important in many aspects, particularly for a decision making in these injuries, presence of an intra-articular loose bodies or impaction or the morphology of fragments is very, very essential. Further, the characteristics of the fracture pattern is well detailed, we'll see in a CT scan. So the sections, what we see here, we need 15 sections to characterize the fracture. And further, as the advances have been made, 3D reconstruction has given a better appreciation. And we can also take an head subtraction films to look into the orientation of the acetabulum and all the views. And you can also have the normal side to compare the morphology opposite side so that we can plan our surgeries. So I took a bone model and I also took a patient example. So on each level, I also cut the bone model with an oscillating saw. I personally appreciated the findings in the bone model and patient CT also, and also the normal drawings from the lateral book. So in the ilium, which is a broad thing, it needs a 10 mm cuts of every 10 millimeters, which is practically 1 millimeter, 1 centimeter. You have to take one cut to look for the orientation of the thing. When we goes into the roof of the acetabulum and the entire roof cavity, there should be a 3 mm, every 3 mm you have to take a cut so that you should not miss any amount of marginal impaction or any loose fragments. Once you go into the operator foramen, the same like a foramen, you can take a 10 millimeter cuts so that the entire sequence of the acetabulum will be seen in the CT scans. So this section 1, where you see the orientation of the iliac wing shape and direction, and also you can see the SA just above the SA joint level. You can see the bone model. This just above the SA joint level. SA joint is clearly seen. In these things, and most of the anterior column fractures where it brokens along with the ilium will be seen in this view, particularly in high anterior column fractures, and also the bicolumn fractures where it extending into the anterior column are well seen. And in section 2, it comes at the level of across the SA joint and the iliac vein, where the most amount of the compression, lateral compression injuries of sacrum are very well seen in an thing. You can see the cut section along the SA joint vein. The other things, it comes at the level of roof of the greater sciatic notch, and the posterior wing of iliac roof will come. Here also it is up to the high anterior column fractures are very well seen in this view. And further, when you go into that, it comes to the anterior part of the inferior iliac spine and a greater sciatic notch. The higher part of greater sciatic notch, where you can see the high posterior column fractures, and also since the anterior inferior iliac spine forms a part of the wall, you see the anterior wall fractures or a low-grade anterior column fractures are visibly seen. When it comes to the subchondral dome of the acetabulum, this is one of the very important where it forms the anatomical roof. It is a very circular in cross section. It is very important to look for the impaction of the anterior wall fragment, and also dome impactions are seen on the anterior side. And the other one is where it's called the corona, where it is the surrounding, the head is completely surrounding the acetabulum, and the head starts appearing where the anterior and posterior walls have been overlapped. And this you can see there's a 2 layer of cartilage is overlapping both on the acetabular side and also in the femoral side. Here is very importantly, you appreciate most of the transverse fractures, it appears like a vertical orientation of a transverse fracture. When you take a T-shaped fracture, it becomes something horizontal. This is one of the important landmark in identifying the transverse fracture. You can see the transverse line and also the posterior wall fracture. This is an example of a transverse posterior wall fracture. And the other thing is simple transverse fracture. Since the orientation of transverse fracture line varies, but it's almost the vertical line is seen in the transverse fracture is well appreciated at this level of section 7. And further, when you go beyond, when the femoral head directly opposes both the columns and it is being separated by the carotid fossa, and also you start appearing the ischial spinalis. And this is one of the very important view where you can see both the posterior wall and also a part of an anterior wall, and also the quadrilateral plate injuries are very well appreciated in this section 8 and 9. And also in this posterior wall, sometimes there are marginal impactions are very well appreciated in the downward sections where both the columns or both the walls are very well visible. And the other thing is the anterior wall becomes obvious, and also the border of the posterior border appears very wider, greater sciatic. Now, these are all the one of the ways where you can see the continuation of the marginal impaction, and also the anterior and posterior wall fractures and column injuries are well seen. Further, when it goes down, the anterior wall disappears. Posterior wall still continues 1 to 1.5 centimeter behind it, so that you can see the inferior part of the posterior wall, and also the part of the anterior wall and the root of the pubic rami fractures are well appreciated. When it goes beyond down, you start observing the obturator canal and also the ischiopubic notch, where you can see the extent of an ischiopubic notch fractures, like a low posterior wall or low posterior column fractures, and also the root of the superior pubic rami fractures are well appreciated in the last sections. When you go beyond section 14 and the other things, you start appearing the prominent neck of the thing, and pubic rami and ischium are well appreciated. In this, femoral head fractures and also the neck of the femur fractures are well appreciated. And the last part is it goes along the most inferior part. It approaches the superior pubic rami and the pubic symphysis. So you can start appreciating the thing. So these are all the essential sections you see in a CT scan. The findings which are not much appreciated on the X-rays are the joint congruency and presence of an intra-articular loose bodies and presence of marginal impaction, and the number and size of the fragments on the posterior side and the anterior side, and presence of a femoral head fractures in the sagittal view. And also you get a three-dimensional view of the fragment orientation, so that your surgeries can be planned. Head succession also, head subtraction films also gives a good orientation. Hence, our goal in all these injuries are, in an acetabular fractures, if you suspect a stable and congruent joint, it should be an assessed in a fluoroscopy to look for the stability of the fracture. When the fracture is stable, you can plan for a conservative management. In displaced fractures, we all aim for an early intervention for a displaced one to get an anatomical reduction, a stable hip, and patient can be mobilized at the earlier. In very complex situations, we can fix it to preserve the bone stock, so that further future joint replacements will be planned on and be an easier task. So here you follow the same patient. The first we have shown a close posterior dislocation. We did a close reduction, and the CT scan showed there is a fragmented posterior wall. You can see in rest of the use. But when you take into the compared to the normal side, the posterior wall morphology at the maximum depth was the 20% of involvement. Our concern is whether it can be treated conservatively or not. As per the Moed et al. Paper, the less than 20% of wall are inherently stable, but 20 to 40% needs a fluoroscopic assessment, and the more than 40% are inherently unstable and needs fixation. Hence, this patient who has a 20% of the wall involvement. So we plan for a dynamic stress evaluation. It is done in the flexion of the hip at 90 degrees, and the adduction and internal rotation of 20 degrees. We can take an C-arm and AP in operator to look for the congruency of the joint. If it is stable, you can plan for a conservative management. An unstable one needs a surgical intervention. So this is the patient, the normal AP view of the thing, where you can see the joint is congruent in AP view. And in an operator, you can see the posterior wall fragment is seen. And when you start observing in a dynamic stress test, you are flexing the hip up to 90 degrees, and you have to bit gently adduct it, and you have to do an internal rotation of 20 degrees. So, and then a little bit of an axial pressure can be evaluated to look for the stability of the joint. Here you can see in flexion of 90 degrees, adduction and internal rotation, you can see the joint is congruent, and the posterior wall is away from the joint, and there is no any evidence of impingement during the testing of thing. This is a patient at 3 years follow-up. The joint is congruent, and patient was able to get a good functional outcome. He was able to restore his all normal activities. So this is to say, when the wall is less than 20%, you can do a dynamic stress evaluation. If it is negative, you can plan for a conservative management. then patient will have good functional outcome. When there is an joint subluxation is there, then you have to plan for a surgery. Here is an example of transverse fracture of left acetabulum. As per Dr. Pradeep Kothadia's the previous talk, it is a bit of juxtatectal to infratectal fracture. When you draw the roof arc angle, the APV, the roof arc angle is 50 degrees, and in iliac view, the roof arc angle is 68 degrees, and in an operator view, the roof arc angle was 67 degrees. As per the description of earlier by Mata and Merit et al., less than 45 degrees of angle indicates the fracture line is going through the weight-bearing area in both an anterior, medial, and posterior side. Hence, the roof arc angle less than 45 degrees, it shows an involvement of the weight-bearing dome. It needs a surgical intervention. Further, the also known Mata have come out to the CT subcondylar, where they form the 1 centimeter of 10 millimeter of the thing is a intact weight-bearing zone. Then the fracture lines are drawn. If the fracture lines are not involving the subcondylar, the patients can be treated conservatively. There is a similar patient in the transverse fracture. Following the 10 millimeter subtraction, the fracture lines start appearing. It shows the fracture line is not involving the weight-bearing zone, hence it can be treated conservatively. There is another patient who had a bicolumnar fracture, right acetabulum. Here you can see the patient has underwent a contrast. There is no flow of contrast in the urethra. It shows the complete transection of the urethra, and also patient had a blunt injury abdomen. So underwent a laparotomy for a blunt injury abdomen, and suprapubic catheter was inserted. Patient had a stormy postoperative period. Hence, this fracture was planned for conservative management. You can see the secondary congruence in the bicolumnar fracture. And a roof arc angle was, even though it is involved, patient is having a good functional outcome. The central protrusion is there. But because of the secondary congruence, it is went on well with a good functional outcome. The other patient was this is 77-year-old man who had a domestic fall and sustained a bicolumnar fracture of acetabulum. As you all see, there is a good amount of quadrilateral comminution and presence of osteoporosis. But the roof arc angle and the acceptable roof arc angle and the hip is well contained inside the hip joint. And these fractures can go on for a conservative management, will give a good functional outcome. Hence, to summarize the thing, when there is a acetabular fracture and the femoral head is congruent with the in APV and Judet views, when there is an positive radiology factors like the intact roof arc angle and the CT subcondylar arc shows there is an weight-bearing dome is unaffected. In posterior wall, if it is less than 50% of posterior was intact in our CT sections, if they are present, patient can go on for a fluoroscopic stress views. If the factors are negative and patient is stable joint on our special use, it can go on for a non-operative treatment. But when there is no evidence of the other things, when the roof arc angle is involving the weight-bearing dome and involving the joint end, it can evaluate for the open reduction for an anatomic reduction, early mobilization. In presence of further comminutions, and you can choose for a non-operative treatment in the initial part of time, and as a part of a salvage, and total arthroplasty can be dealt at a later stage. When the patient is 60 years and presence of serious comorbidities and increased surgical risk, also the pre-existing arthritis and low demand patient also can be treated conservatively for some point of time, and later can go on for a total replacement if functionally patient is having a disability. Otherwise, in the presence of a good surgical experience and an institution, all these injuries of displaced acetabular fractures can be managed with a single approach or dual approach depending upon the fracture pattern, will give a good functional outcome. If the complex injuries, it is better to transfer a patient to a center where the pelviacetabular surgeons experience, so they can go ahead and give a better outcome. Hence, to conclude, the understanding of CT is very useful in decision making in these injuries. Definitely, conservative treatment has a role in acetabular fractures, particularly in an undisplaced and elderly patients. Dynamic stress test is very useful in posterior wall fractures, and displaced fractures need an early intervention for a better functional outcome. So, thank you for your patient listening.
Thank you very much, Dr. Ramesh. And I think we have very clearly mentioned the role of conservative treatment. I would just like to add one very important point with this. That is, a conservative treatment in acetabulum fracture requires a more stringent monitoring as compared to an operatively treated acetabulum fracture. So that is one thing that everybody has to understand. It is conserved, but it is not neglected. Now, I request Dr. See, we have now X-ray diagnosis, we have a CT scan diagnosis, we have decided that we require a surgery for our fracture pattern. So now comes the approach, how you reach to the acetabulum. All of us know that it is one of the deepest joints and it is one of the most difficult to properly approach. So our masters will now take us through 4 most basic approaches for acetabulum fractures. And I invite Dr. Sameer Agrawal to start with the Cocher-Langenbach approach.
Good morning, everyone, and happy Teachers' Day. I'm thankful to IOA and IOPAS who has given me this opportunity. I will be talking about, the Cocher-Langenbach approach, which is a workhorse for reduction and fixation of fractures, which requires posterior approach. In fact, it was in 1867, the Langenbach has told about this approach for the hip infections, and Cocher was his student who changed this approach for the added the distal fragment of longitudinal over the femur and given this Cocher-Langenbach approach for acetabulum fractures. It provides direct access to the outer surface of the posterior wall of the acetabulum. So main indications are whenever you require to operate on the posterior wall or column, transverse, juxta, infratectural fractures, which has been told by Dr. Kothadia, combined fracture type where posterior column or wall need direct regions. There are some type of fractures where you need to fix the posterior wall and assess. It gives the direct access, visual access to the dark. This is the posterior wall, posterior column, and some part of the superior surface of the acetabulum, and indirect access to the quadrilateral plate. You can feel the quadrilateral plate in this approach. The position, it can be done in lateral or prone position with legs freely mobile. Most of the butt area to be uncovered, and during surgery, the hip has to be in extension and knee must be kept in flexion so that there is no stretch over the sciatic nerve. The skin incision, greater trochanter is the main point. From few centimeters distal to the posterior superior iliac spine, incision anteriorly over the GT, curved distally toward the lateral aspect of the shaft of the femur to end the incision at the distal to the insertion of gluteus maximus tendon. We do the sharp dissection of subcutaneous tissue along the gluteus maximus muscles and iliotibial tract. And after that, we split the gluteus maximus muscle proximally up to the crossing of the first neurovascular bundle. That is the branches of the inferior and superior gluteal artery. And this muscle is divided into posterior muscle belly and anterior muscle belly, so that to include 1/3 of the gluteus maximus and tensor fasciae lata in the anterior surface. One should avoid gluteal vessel injuries. The superior inferior gluteal vascular bundles supply the gluteus medius, minimus, and the gluteus maximus muscle. So one has to be very careful to avoid injuries to structures so that there's no wasting after this surgical interventions. When we want to extend, we can 1 centimeter from the insertion of gluteus maximus tendon, we can cut it partially or complete, allow decrease in the tension of the mobilization of the gluteus maximus muscle. So this step is very important. You have to cut it, but you have to resuture it once you complete your surgeries. This is the dissection I can show you. This is the posterior superior iliac spine. This is the greater trochanter. And the incision is in the line of lateral aspect of the femur shaft between insertions of gluteus maximus at this point till the greater trochanter, and then toward the posterior superior iliac spine in line with the gluteal muscle fibers. Subcutaneous tissue is cut and fascia lata over the lateral aspect of the femur is exposed. Now you have reached that fascia lata, and then you go proximally, expose the gluteal fascia and You can cut the fascial artery with a scalpel. And now you have reached the point of greater trochanter. Don't cut the gluteal muscles. Just do the blunt dissection. And your dissection should be approximately till the point you find the neurovascular structures. You must remember that there are external rotators, piriformis, obturator internus, and gemelli. Your piriformis comes and it covers the greater sciatic notch. Your sciatic nerve is just anterior to piriformis muscles, and all the obturator internus along with the gemelli, they come out of in the lesser sciatic notch. Like in this case, and you have to remember that the vascularity of the head of femur is by the medial circumflex femoral artery, which runs along the quadratus, and you have to avoid the injury to this medial circumflex artery. So you have to cut your muscles, external rotators, 1 centimeter proximal, 1 to 1.5 centimeters, and you must avoid cutting quadratus femoris. You have to identify each and every external rotators during surgical dissections, so that this area where this medial circumflex vessel is there, you have to avoid injury to these vessels, and you have to be proximal to this area. The tip is you cut these muscles near about 1 to 1 centimeter proximal to this, and proximodal of quadratus femoris should be identified, and your cut should not extend into the quadratus femoris muscle to avoid injury to the vessels. You should be able to identify both greater sciatic notch and lesser sciatic notch by this orientation of these muscles. Once you cut it, you reflect the piriformis, you make it free from the posterior surface, and then you can greater sciatic notch, then there's a lesser sciatic notch, then you can see the posterior aspect of the capsule and the hip joint. You must apply stay sutures before division of piriformis and external rotator muscles, so that you can resuture it to the. So this is. So from here, we try to identify the quadratus. Then you identify the sciatic nerve. It's a constant relation of this sciatic nerve with the quadratus. And you do identify all the external rotators, obturator internus. This is your piriformis. Identify it. And then 1 centimeter to 1.5 centimeter, apply tag sutures to obturator internus first. You can apply 1 suture or 2 because this has a very less number of tendinous fibers. Mostly it is muscular. And then you do the piriformis, tag it, and then you cut the piriformis. And with the help of balloon dissections, you can do this. You can see the fracture here. This is in the superior aspect, and now we are cutting the obturator internus. And then you go deep, try to separate it, reach the capsule. Please don't cut the capsule at this level, and try to go towards the greater sciatic notch. Once you have reached the greater sciatic notch, put a retractor, that is a greater sciatic, to protect your sciatic nerve. Do the blunt dissection, and now you have reached the greater sciatic notch, and you can put a retractor here, lever. This is the posterior column. Erase the fibers, and you can put another retractor in the lesser sciatic notch. Now you can see whole of the posterior wall, posterior column. This has been done just to show you that otherwise don't use the cautery at this level. Now you can see the fibers, obturator and piriformis. You can suture it, and there's very minimum injuries to these external rotators. we see this is the obtuse quadratus. We have identified this nerve, sciatic nerve. Then we have done suture. This is obturator internus with gemelli, superior and inferior gemelli. This is your piriformis. So these identification of these structures are very important, and injury to sciatic nerve has to be avoided. There should not be any stretch. During all dissection, the hip should be in extension and knee should be kept in flexion. So your sciatic nerve is protected by these rotators. And you have to remember that in 84% of cases, your sciatic nerve is anterior to piriformis. But however, in 12%, the peroneal division is through piriformis. And in 3%, there's a division like this. There's a split of the sciatic nerve. Half of it goes posterior to piriformis, and tibial division is anterior to piriformis. So you have to remember this anomalies in the sciatic nerve. So while dissection, you have to remember this. And now you can see the posterior wall after releasing of all the short external rotators. Your retractor is in the external, this retractor is in the lesser sciatic notch, this is the superior. So after that, you can see the joint, you can inspect the joint. This is the labrum, basically, and you can invert your fracture factors and inspect the weight-bearing dome, femoral head, see for any infection, damage to cartilage, sternum, femoral head. Like in this case, there was impacted fracture. It has been elevated now, and there's a gap. So you have to fill this gap with a bone graft. You can use a raft screw, or you can put another graft, cortical graft, and after that you can do the fracture reduction either with help of temporary KYs or reduction forceps. And after that you can fix it with the recon plate temporarily first, and then you can do it. So, but before closure, you have to debride all the necrotic soft tissues and to irrigate the wound to decrease the chances of hypertrophic ossifikations. Most probably the gluteus minimus muscle is the main, which is necrosed in these cases. You have to reinsert all the muscle. You have to resuture these muscles with the tack, not with the bone. And once you do it, closure is there. In some cases where you want to reach on the superior aspect of the acetabulum, you need a trochanteric osteotomy. For this, you have to first mark the area. This osteotomy is from greater trochanter to the vastus lateralis, and vastus lateralis insert on the vastus tubercle. And you have to, in this case, you have to incise some part of the vastus for extra pyrostral mobilization, like this. You mark, this is the greater trochanter, this is the vastus. You mark your osteotomy with the osteot, and this is vastus lateralis, you can see. Then see, with the K-wire, help of K-wire, you can mark your direction of the osteotomy, and with this drill, you can do it. And sorry. With the osteotome, use help of 2 osteotome and slowly do complete the osteotomy. With the 2 osteotome, try to invert the trochanter. Cut the remaining part of the gluteus medius and vastus lateralis so that you can see whole of the capsule here. You can have, this is the acetabulum. You can see the hemi-circumferential view of the acetabulum surface, and anterior capsule exposure require mobilization of the proximal portion of the vastus. Flex, externally rotate the hip, improve the exposure, and you can do the capsulotomy for safe surgical distribution. But during this period, you have to remember that this is the labrum and this is your vascular structures. So you have to do the osteotomy, capsulotomy 1.5 centimeter lateral to the edge of the acetabulum to avoid injury to this vascular surface. And closure is very easy, just you put it back. So in Kocher-Langenbach, one should remember that there are chances of infection like in other surgery. The reported incidents are in literature at 2 to 5%. Sciatic nerve palsy is 3 to 5%. And mostly detector is often held by inexperienced assistant. So one should relax on the nerve every chance you get and try to keep the hip in extension and knee in the flexion every during the surgery. Hypertrophic ossification 8 to 25%. For this, you can debride the non-viable muscle tissues and you can start indomethacin or can do the radiotherapy. And superior gluteal injury is one of the most complication of this Kocher-Langenbach. If you injure this vessel, please pack it, wait for 10 to 15 minutes. And most of the time, this bleeding stops. And one should avoid injury to the medial femoral circumference artery just by not going there. Thank you.
Thank you, Dr. Sameer, for nice videos on Kocher-Langenbach approach. And we have Dr. Lokesh now with us, who is going to take us through the anterior intrapelvic approach, which is now increasingly replacing the need of Ilio-Inguinal approach. So, Dr. Lokesh, we welcome you.
Okay. Am I audible now? Yeah. So, let's get there. So, good morning, everyone. And I thank the IOA and the AOPAS for actually starting this web series of webinar series of acetabular fractures. And the first thing was the basic approaches and the anatomy. So my contribution would be to talk about the anterior intrapelvic approach to the acetabulum, which has become more and more popular of late. It is almost, we cannot say replacing. So more fractures are being fixed with the anterior intrapelvic and ilio-femoral approaches combination than the ilio-inguinal nowadays. So Stopper described this approach in 1975 as a subperitoneal median approach for the treatment of groin hernias. And in 94, Cole and Bollhoffner modified this, and you're going to stand on the opposite side of the affected hip and operate, and we can fix the inner part of the acetabulums with this. So they described the hip joint reduction, fracture fixation, and acetabular fixations with this approach. So what are the fractures that can be fixed with an anterior intrapelvic approach? We can fix anterior column fractures, anterior column and posterior hemitransverse fractures, anterior wall fractures, bicolumnar fractures, and T-type fractures. And why I have actually mentioned geriatric fractures as a separate entity is because nowadays we find more and more geriatric fractures. There is almost a threefold increase in the past decade, and majority of geriatric fractures, to the tune of about 70%, are anterior injuries. Unlike a typical younger person having a acetabulum fracture, which is mostly posterior, dashboard injuries, most of the geriatric fractures are anterior. Like we see here, classically in geriatric fractures, we have anterior column displacement, quadrilateral plate involvement, medialization of the femoral head, and superior medial dome impaction that can only, or rather the best way, be managed only with a anterior intrapelvic approach or the modified Stopper. So the patient is going to be in a supine position. The limb is to be draped, the affected limb is to be draped separately. The surgeon stands on the opposite side. Urinary catheter has to be in place. Hip and the knee has to be flexed. So this is what we have to do. So we have to separate the perineal area. we have to keep the umbilicus exposed to see the midline. And how do we go about it? And what can we see with this approach? We can see literally the entire part of the true pelvis on the side of which we are operating, from the pelvic brim down to the ischial spine, and lower part of the upper parts of the ischium can be seen with this. And we can also, about a couple of centimeters superior to the pelvic brim, we can see the area anterior column, and we cannot extend this superiorly into the iliac fossa because of the bifurcation of the common iliac into the external and internal iliacs. So that is the limit to this. So we can add a lateral window to actually fix the upper part. So that is the area that can be seen. The brown area is the area that can be seen. Pubic symphysis, the entire quadrilateral surface, and that's the brown colored area. The blue colored area can be reached through the lateral window. So we can see the whole of the acetabulum, anterior column, and the anterior part of the innominate bone through these two windows, and we can fix the fractures with this. So actually, to summarize, or rather to put it in a concise manner, there are 10 steps to getting a good anterior intrapelvic approach. So the first one is a fan and steel transverse skin incision. Okay, and we have to raise the proximal and distal flaps subcutaneously. And then we actually split the rectus abdominis and protect the bladder end. Next is we have to place 4 retractors. So I'm going to tell it now and I'm going to show it later. The first one is behind the pubic tubercle. The second retractor is in the psoas fossa, psoas gutter, or towards the AIIS. The third retractor is in the posterior aspect of the medial portion of the pelvic brim. That is in the sciatic buttress area, superior to the pelvic brim. And the fourth retractor is placed in the lesser sciatic notch. So I would repeat: pelvic tubercle, psoas gutter or towards AIIS, the sciatic buttress area, and the lesser sciatic notch. These are the 4 retractors that are going to be placed. And we're going to be, what is the nerves and vessels we have to take care of? We have to take care of the external iliac vessels, the internal iliac when we are placing third retractor, operator now. Okay, so these are special retractors which are made of carbon fiber, which can be used. So it's actually numbered also, retractor 1, 2, 3, and 4. And we have provision for using K-wire into those slots, and we have a light illumination also available. So of late we have started using these, and it really makes our job very easy and comfortable because they are carbon fiber. They don't even come in the way of our viewing. So it's pretty comfortable. So they are the 4th retractor. The one on the left is the 4th one. The one on the right is the 3rd one. This is the 1st and the 2nd. That's for the pubic tubercle. We'll see the picture, how it goes. So that's where it is. So that's for the pubic tubercle. That's behind, in the psoas gutter behind the AIIS. That is, we put a K-wire here in this superior to the pelvic brim in the sciatic buttress area. And that's one is going into the lesser sciatic or the greater sciatic notch. So depending on which area we want to. So that is the area that's going to be exposed, and you're going to stand on this side. Okay, so draping, as I mentioned, ipsilateral hip is flexed for 40 degrees to relax the iliopsoas and the external iliac vessels. And we keep the drape such a way that we can put a lateral traction pin and pull the head out, which is required in some instances when there is medial impaction. So we need to keep that area also exposed. And the ipsilateral limb is to be draped separately for maneuverability. So catheterizing the patient is important. Keeping the umbilicus exposed is important. Excluding the perineal area is important. And keeping provision for maneuverability of the limb and for a lateral pin traction with the hip flexed. So these are important. So it's a typical fan and steel incision. And as we see that it is not very wide incision. Typically, unlike what people believe that the wider the incision, the greater the exposure, is wrong, because to fan and steel incision, with a regular fan and steel incision, we can reach out to even the posterior part of the sacroiliac joint also. We don't need a wide incision. And what we do is just above the pubis, and then we identify the rectus, we split the rectus, and then we subcutaneously elevate superiorly and inferiorly. You see that? We subcutaneously elevate superiorly and inferiorly to identify the rectus. So for the rectus to be split adequately. So it's very important to subcutaneously elevate at least for about 4 centimeters proximally and distally. We have to elevate subcutaneously and expose the rectus before dividing it. So this is how we have shown the picture of how do we release the rectus. So in the first picture, as you see here, the rectus is split here, but the incision is widened and stretched so that the rectus release. First pointer is subcutaneous elevation and splitting it vertically for a longer distance, number one. Number two, elevating the rectus from the anterior pubis. It's very critical so that we can actually elevate it and actually see to it that the rectus can be flipped a little laterally so that we can visualize the interior of the pelvis better. The third one is you have to run your finger on the underside of the rectus, release any adhesions to the bladder. This is the three things we have to do before we go into the rest of it. Next, what we have to see. Once the rectus is retracted, as in seen in this picture, we have to identify the corona mortis, which is a vascular communication between the external iliac and the obturator vessels. So it's very small and thin in this area as marked by this arrow. So we have to ligate it in a normal scenario. It sometimes can be very big and it has to be, we can use liga clips or tie it off or buzz it. Either way, it has to be taken care of before we go further. The next important anatomical landmark we have to identify is the iliopectineal fascia. We have seen iliopectineal fascia in ilio-inguinal approach. Here how it looks. So this second picture with the arrow shows the iliopectineal fascia, which is a fascia that is coming from above and going superiorly like that. So that's the iliopectineal fascia. So in an ilio-inguinal approach, we're going to cut it from top. Here we're going to elevate it from below. So we're going to run the knife, scalpel, sharply along the brim from anterior to posterior to elevate this iliopectineal fascia. And it's very important to elevate this iliopectineal fascia. So what do we do when we do that? So, and these are the structures I was mentioning. The most common thing that can be damaged is the external iliac vein, which is just lateral to our pelvic brim, and it has to be taken care of, especially when you're putting the second retractor. The anteriorly, what is there? Corona mortis, we have to take care of that, and the obturator nerve. These are the three main structures we have to locate and take care. So that's a big corona mortis picture, how the obturator, and we have the obturator nerve also there, how it looks. So we have to be carefully in ligating it. So then, where do we apply the first retractor? If we apply the first retractor, so behind the pubic tubercle. So we see the first picture showing the application of the first retractor with the K wire there. So then we actually subperiosteally elevate this area. So we have the troughs and hills. So we have the pubic tubercle, then there is a trough there where the vessels go, and then we have the iliopectineal eminence, and then again we have a trough, which is the psoas gutter. So in the second trough, as we march from medial to lateral, the first is the vessels, the lower area where the vessels pass, the iliopectineal eminence, and then we have the psoas gutter. That is where you pass your liver. So that's the liver being placed in the second. So you have, if you go subperiosteally, there is very less chance of damage to the vessels. So that's how you place your second retractor in that region, in the psoas gutter. So as you see, the second retractor is placed, and then we place the third retractor. So we have actually elevated. If you see, we can see the pelvic brim and the superior and inferior part of it. So we can place a plate infrapectineal and suprapectineal. Here we have the pectineus muscle in this area usually. So we have elevated it all. So, and we have used the third retractor. That's the third retractor with a K wire placed. So it can be placed there, and we are actually able to see just here is the sacroiliac joint. And throughout we can use a flexible deverse retractor to retract the bladder back medially, and we can see the whole extent of the pelvic brim exposed superiorly for a few centimeters, and also the whole extent medially. So then what we do, we have to identify the obturator nerve, as we seen here in this picture. Obturator nerve is identified, and it has to be where it penetrates the obturator membrane inferiorly. We have to release it a little. we have to keep it a little mobile because the chances of stretching are there. Then there are parallel to this obturator vessels, which can be preserved, but they are expendable. We can actually ligate them if it causes a lot of bleeding. So we see here now, that's the fourth retractor placed and the whole of the quadrilateral surface is exposed. So we see that, so that is the pubis, the superior part of that's the iliopectineal eminence, that's the pelvic brim, that's the sciatic buttress, and that's the posterior column. Can you see that? That's the posterior column. They put the fourth lever in the greater sciatic notch. And the operator nerve is here. So we can go above and below that. And we can actually put a plate here also. This is where the head is going to be quadrilateral plate. And this place is the posterior column. We can put a plate here also. So this is how we expose the quadrilateral plate. So as I was mentioning, the bifurcation and if the or the ilio-femoral approach itself with the ASIS osteotomy can be used to get here. And what are the special reduction clamps we use? There's something called the offset quadrangular clamp, which is shown here in this picture below, which is offset means it is actually bent here. So this is what is used. What are the areas for putting the clamp? One is here in this region, just below the superior pubic ramus. We can put it in the inferior lesser sciatic notch area, and of course above the pelvic brim. And we can use the regular Weber's clamp or pointed reduction forceps. Ball spike is used if there is any anterior bulge here. And of course traction, longitudinal and lateral pin can be used. So the chances of injury to iliac vein, operator nerve, superior gluteal vessels and corona mortis, as I mentioned, bladder should be taken care of, and too much of retraction can cause thromboembolism. Some case examples, this is a case of geriatric fracture, dome impaction. We can see that the medial part of the dome is impacted. We approached it through the SOPA approach and we use the fracture area to reduce it. Can you see that we are reducing that dome impacted part back in place? Usually, normally we are supposed to put what's called the raft screws, which is just above the dome area so that the depression is not occurring again. We can put a couple of screws here. We have not done it. So that can be used, and we have put a intrapelvic plate to fix this, and the hip is reduced. And we actually have bone grafted this area. So the next one is again a 68-year-old female with medial impaction injury, so that we can see the anterior column is fractured. And the CT scan, we can see medial displacement of the same. And there is also, whenever there is an implosion injury, there might be some posterior wall fracture also. So that is the anterior column split superiorly and medially. It is into two pieces. So we have to put this back in place, press it down and pull the head out. And that's how we're going to fix it. So we have a suprapectineal and infrapectineal plate, as you see here. So what did we do? We actually put this fragment back and put a medial plate, press this fragment back into place and put a superior suprapectineal plate and give a lateral traction. And we see that the head is congruent here, as is seen in this picture. So we used a STOPA approach. The third one is another gentleman who has a anterior column fracture there, which is the CT scan showing 55-year-old gentleman. And there's the CT scan, which shows impaction in the dome area. And we have used a STOPA and an ilio-femoral to get it back. So, and why I chose this is, I told you there is a posterior wall fractures that can be happening. This is the only instance in a bicolumnar fracture that we use posterior wall fixed through this screw from anterior to posterior. Otherwise, we have to expose the posterior wall. So that's the next case, which is again medial implosion injury, 67-year-old male fall from a two-wheeler. Most of these are anterior column fractures, geriatric fractures. So we can see that there is dome impaction and medial displacement. That's how it's going to be. There is the suprapectineal part is displaced anteriorly. The infrapectineal part is displaced medially. And what do? We actually put a suprapectineal and infrapectineal plate through a STOPA approach. And a lateral window is used. Another case, 72-year-old male, that's a CT scan, supra and infrapectineal plate being used. This is another gentleman with a pelvic and acetabulum injury. So there is a bicolumnar injury and a 15-year-old male ABC fracture pattern. So what do? We actually do the same. This is how it looks on a 3D CT. And of course, we use Ilio-Femoral approach and a Stopa approach, and the head is reduced back in place. What we have done here is we have done a posterior column plate, which I was showing in the cadaveric picture. We can put a posterior column plate to fix the posterior column with this approach itself. And these are called the magic screws. From behind the AIIS, we put it and hold that. There was a fragment going down. If you see here, this fragment that's going down, it's fixed to the lateral side with these screws. And of course, the ilium is reduced on top. So Stopas is that's a 4-month follow-up. So Stopa is or an anterior intrapelvic approach is a very versatile approach with significant application in anterior injuries. Dome impaction and quadrilateral plate injuries are best addressed with this approach. Combining with lateral window or ilio-femoral approach can help in dealing with all anterior injuries of the acetabular. Thank you for your patient listening.
Thank you, Dr. Lokesh. That was very nice pictures of your Stopa approach. And from here, we move on to Dr. C.P. Das, who is going to show us the beauty of the Ilio-Inguinal approach, because Ilio-Inguinal approach is probably still considered the gold standard. It gives the best exposure of the overall acetabulum anterior column. So over to you, sir.
Thank you. Good morning, friends. Dr. Lokesh has made a wonderful presentation, and he has made my life easier. He has shown the MIS part of the Ilio-Inguinal approach. So we'll start with this. Well, today is Teachers' Day, and I think we'll start our lecture with offering a tribute to the master, the ultimate master, Professor Emily de Tournelle, who described the both Cocher-Langenbach and the Ilio-Inguinal approach in 1964. And this is an anterior approach, and this is what you get at the end of your exposure, from the sacroiliac joint to the pelvis symphysis, and all the important structures like external iliac vessels, the spermatic cord, the femoral nerve, very well taken care of in this approach. There is an evolution in this approach since it was described by de Tournelle. I will tell you a little later. We'll talk about de Tournelle's classical approach. My talk is, basically, as our moderator has told, that this approach, Stopa's approach, is a very advanced approach. And if you know how to do Ilio-Inguinal approach, you will do a better Stopa's approach. And the Ilio-Inguinal approach is though it's a non-extensile approach, it's a very versatile approach, and it gives you access to a whole lot of things, and without any special gadgets. And if you injure anything, you will tackle it better in this approach than like you are doing a laparoscopic cholecystectomy and you cut cystic artery, and if you do not know how to do laparotomy, you probably will lose the patient. Same thing. I mean, if you are doing a Stopa's approach, if you have an injury to a major vessel, you are in deep trouble. So knowing this approach is very essential. And in the early part of my practice, from 1995 to 2008, all my anterior fixations were Ilio-Inguinal approach. From 2008 to 2013, about 20-25% cases became Stopas. From 2013 till date, I have only done one Ilio-Inguinal. That is to demonstrate to one of my fellow acetabular surgeons. So, slowly you have gone into Stopa. But I still love this approach. And this is in the green part is what you get, the inside of the pelvis. You see so much, the whole of both the columns you can approach through this approach. And on the outer aspect, still you can have some direct access to the anterior part of it. And we should learn at the end of this talk what are the indications, contraindications, how to set up theatre is very important, what are the surgical steps, and how to avoid the risk to the important structures. As I mentioned to you, most of the anterior fractures and anterior column and posterior hemitransverse fractures are very easily fixed with this approach. There are associated both column fractures with a large single posterior fragment without combination of the sciatic area can be fixed with this. Occasional T and transverse fractures are also very comfortably fixed in this one. here like these fractures. And you know, a fracture like this, you can fix it from the front if you have a collinear reduction forceps. You can reduce the posterior column onto the anterior column with this approach and very effectively treat this. This is a contraindication if you have somebody who has got an injury in the bladder and you really don't want to go in and infect the whole thing, or you have a suprapelvic catheter which is infected. So when you have a pelvis or acetabular injury, you speak to the urologist regarding the placement of this catheter if you are planning to do ilio-inguinal approach. So these are contraindications. And if somebody has a CS or somebody had a ruptured uterus which was taken out in the front, or maybe a hysterectomy from the front, or maybe even people who have this bilateral tubal ligation who got infected, who struggle to get a good exposure in this ilio-inguinal approach. Theatre setup, this is the ideal setup, an eccentric table, radiolution top. Often we don't find this, we can join two foot end of the standard table with taking care of the metal bars in the side and the patient positioning like this, and you need to make sure that your views like Jude views, AP views and the inlet outlet views are not obstructed by the metal bars, and the C-arm remains on the opposite side, and this is how you rate the patient. And the bony landmarks are sacroiliac joint to the uterus symphysis, everything is exposed from the inside, and the red line shows Retornel's classical ilio-inguinal approach, which has been modified by the AO people, mostly by Keith Mayo. When he has added the midline section, I think he has taken Lokesh's approach, Topa's approach, along with the ilio-inguinal. You get a beautiful exposure of everything. But anyway, this is a very large exposure and is only meant for some delayed cases and more complex types of fractures. So coming to the steps, this is the classical incision. You see the incision always starts on the opposite side of the midline, about a centimeter from the opposite side and 2 centimeters above the uterus symphysis, and runs parallel to the inguinal ligament to the anterior superior iliac spine, and then goes backwards to iliac crest, gluteal tubercle, and then goes upwards. I will tell you why a little later. And this is how the skin incision should be. You see here, this is the midline, and the incision starts on the other side. And gentlemen, the cadaver has been cut parallel to the ilio-inguinal ligament, the inguinal ligament come up to the anterior superior iliac spine. Then along the iliac crest on the outer side, you need to identify the overhanging insertions of the external oblique muscles onto the iliac crest to get the tendinous insertion, and then dissect it from there, and then slowly dissect it towards the iliac fossa, so that you have a tendinous tissue to repair when you are at the end of the closure to prevent a hernia. This is where you find, and then this is also this is the overhanging insertions of the abdominal external oblique aponeurosis, and you need to slowly erase it from the outer surface of the iliac crest. And once you have erased it with a thick cuff of tissue, then you need to go inside and take the iliacus out of the inner table of the iliac crest, and then pack it with a sponge. This is in the cadaver. This has been taken off. The iliacus has been taken off and packed to the sponge. After that, you go to the anterior part of the incision. The anterior part, as you mentioned, that you start with the PB tubercle about 2 centimeters above that, and come to the anterior superior iliac spine. Then you identify the external oblique aponeurosis. Then make an incision just as you made in the skin incision, the same line, a little above the external oblique, opening of the inguinal canal. And I'll show you this video. This is starting from the midline, just across the midline, and going laterally towards the anterior superior iliac spine on the anterior part of the abdomen. You see, it is very important to have the sticky airway sticking to this place without being lifted up, because very close to perineal area, and if it gets lifted up, you can have contamination from the perineum and infections. This is the external oblique aponeurosis, which has been lifted, and you need to stay above the external ring of the inguinal canal, and very neatly cut this tissue, because you need to repair at the end of your procedures, and catch it with backwards tissue holding forceps, pull it downwards, and this is the conjoined tendon which has been dissected from the inguinal ligament. And then you need to identify on the lateral part, about within the 1 to 2 inches of the ASIC, you find the lateral cutaneous nerve of the thigh. You or dissect it proximally and distally to make it loose. And then this is the most important part. You see, I am putting a mark on the pulsation I am feeling on the external iliac artery. Your conjunct tendon is cut up to that only. This is a better version of the approach. You stop at that point because you know that is the point where you have the ilio-pectineal fascia, and you don't need to cut the conjunct tendon in front of the vessels because that gives a lot of protection during the surgery to this tendon. But this is what I have done. This is from the picture from the AO, and this is what Detonel said. You cut the whole thing from middle to the pelvic tubercle to the ASIS, but leaving that part of the tendon intact helps you to handle the vessels very well. And then you tag the round ligament in the females or the spermatic cord in the males coming out of the external inguinal ring. And then once you have done that, as I mentioned to you, avoid incision of the external iliac vessels. We have already identified the lateral cutis nerve of thigh, and now we need to identify the ilio-pectineal fascia. Dr. Lokesh has shown from the behind in the stopage approach. Here you are seeing from the top. See, you have cut up to the vessel as felt by the pulsation of the external iliac artery, and here you need to take off this iliopsoas tendon from this ilio-pectineal fascia, then cut little bit in front of the vessel, the conjunct tendon, and go to the other side of the ilio-pectineal fascia. This is the ilio-pectineal fascia, and once this ilio-pectineal fascia is identified, it is dissected. You need to get the vessel out of the place by putting retractor on the medial side, and you need to identify the vessel. You will see the external iliac artery on your side. That's the external iliac artery, which you will see and feel for the pulsations. And this is the ilio-pectineal fascia you are seeing, and this is the pulsation, and that's the vessel. Okay, and this then you need to cut this fascia, the ilio-pectineal fascia, go from the front to the back. Dr. Lokesh shown from the back, the lateral aspect, but you go from the front to the back. You, in some cases, you may have to excise the whole thing. This is how you cut, and this is a very thick one, and maybe you need to excise this. Just by cutting won't help. So you really, once the vessel is protected by medial retraction and the femoral nerve protected by the lateral retraction, this ilio-pectineal fascia you need to cut completely right up to the superior surface of the pubis, and then go behind the ilio-pectineal tendon, the iliopsoas tendon, towards the sacroiliac joint. This is on the superior surface of the pubis. Now you are going behind the tendon of the iliopsoas tendon. So you really need to take care of this part. Sometimes when you cut this, you really anticipate, you need to look for, this is the ilio-pectineal fascia. When you cut, I found that there was a big vein. It was a corona motis. Corona motis in stopa you see in front of you. Here you see it at a depth. This is a big disadvantage. It's a vein. You need to ligate it, but you find, then you look for the artery also. It has been described that corona motis can be a vein alone or can be an artery alone, or sometimes, or more often you find both vein and the artery. Once you find the vein or artery, you look for the other one before you go ahead further, because if it bleeds inside at the depth, again you will have a problem. So you really need to locate, stop all your dissection, then locate the external iliac, the corona motis artery. So I am looking for the corona motis artery, and this is the artery you can see at the depth. That had to be identified and ligated before I went ahead with further dissection. So at this juncture, before you cut the ilio-pectineal fascia, you need to locate that. Once you are comfortable, you have ligated the corona motis, and you got the external iliac vessels very well tagged. This is the iliopsoas tendon. You need to pull it to the side, and then go behind the tendon straight towards the sacroiliac joint, as Dr. Lokesh was mentioning, and erase the ilio-pectineal fascia so that you get an entry to the true pelvis. So this is entry to the true pelvis. Once you have done that, again you need to go towards the pubic tubercle behind the vessel in this fashion. You really need to cut the ilio-pectineal fascia, lifting the vessel, and go towards the pubic tubercle. And once you have done this, you have this small full exposure of the Ilio-Inguinal approach. Then you need to put these structures into different loops. This is the lateral loop, which is going to get the iliopsoas tendon, the femoral nerve, the lateral cutis nerve of thigh into the lateral loop. Then you need to get the vessels into the middle loop. While doing so, you keep your hip flexed, because it will relax the vessel and prevent any kind of injury. and keeping the hip flexed helps you to get all the anterior structures relaxed. So then you need to get the inguinal, the lymphatics, the lymphatic nodes and the lymphatic channels is the most medial part of this thing, and is the most medial loop. And when you hold these loops, you can play around and look for the fracture reduction, and then pass with implants and do whatever you want to do with the fracture fixation. So this is the lateral window and the middle window, and once it is done, you can pass the metal implant after being completed from the lateral to the medial side. This is on the pubic bone, and you need to start fixing at one of the ends. This is how it is fixed. And you see, if you have a good exposure, you can see the hip joint. You can debride it. There are intra-articular fragments which can be irrigated and taken out. Otherwise, it will form bone debris, and there will be very early degeneration. And then, of course, you start using your instruments to reduce these fractures and fix them. This is the bone spreader for debridement, and this is just starting with the instrumentation to start reducing this. And then, once the fracture is reduced, you template it, and according to the template, you prepare your implant for fixation, because the implant otherwise can produce a malreduction during fixation. And once you have done that, irrigate it nicely, remove all the debris, check for the corridor being okay. It's a 3-dimensionally molded implant in this particular case. Pass it from the lateral to the medial side, lifting all the loops one by one and checking through different windows so that you don't catch any tissue while passing it. I normally pass with a ribbon gauze being attached to the other side, so that is safer. So you check that and reach the pubis, and in the pubis side, once you find it, you dissect the side where you want to put this implant, and then start fixing on one side. When you're fixing, please make sure this is the ilio-pectineal fascia on the medial aspect, which is up to the pubic tubercle, but not removed very well. So you have to remove it and leave room for the implant. And once you have put the implant, check on the C-arm, and then you put the reduction clamps, and again recheck in the C-arm, the operator view and the iliac view, and then start fixing on one side. When you put the implant gets displaced. You need to allow this reduction forceps to be released so that the implant moves out. Otherwise, you fix in the same position, you can produce a malreduction. Once you have done that, go ahead with the. I prefer to put the self-tapping screws for the convenience. You really need long drill bits and long gauge to do this fixation well. Then you, of course, go by the sequence. And once you have done the fixation, you really need to have a good look at the total bone. Check for all important structures starting from the lateral side, the iliopsoas muscle and tendon, the femoral nerve, the lateral cutaneous nerve of thigh, then the important vessels, the external artery and vein, and then go to the medial compartment and wash it out nicely, remove any bone debris. Then, of course, the most important part is the closure of the wound. This is what you see, and this is what you need to check and make a record of that for your operation. This is the nerve which has been sort of traumatized, but the patient didn't have any issue with the lateral cutaneous nerve type. And we should know what is a safe zone. This is a safe zone. You should avoid putting screws between the anterior inferior iliac spine and the ilio-pectineal eminence, and the neighboring screws should direct away from the acetabulum. I just want to show you the lateral cutaneous nerve of thigh is very variable in its position. I have seen it from the over the iliac crest at the ASIS, and last one you saw was about 3 centimeters away from the this thing. This is the anterior iliac spine, and you see in this particular case the lateral cutaneous nerve of thigh is just at the anterior iliac spine. So you really need to be careful so that you don't miss, or you cut. Sometimes, of course, you have to consent your patient that this can get injured and patient may have paresthesia in that unpleasant sensation over the area following the surgery. Then the closure is most important. Close the conjunctiva very carefully, taking care to close the floor of the inguinal canal so that you don't get an hernia. And when you close this, you don't squeeze the spermatic cord area around the area, although you have a very refractory edema of the vulva, the scrotum on that particular side. Then when you close the external oblique aponeurosis, again do give little bit of relaxation for the lateral cutaneous nerve of the thigh, otherwise you will end up with some scarring and neuralgia, paresthetica-like sensation. So the structures which you need to take care of, coronal arteries, lateral cutaneous nerve of thigh, external iliac vessels, bladder, femoral nerve. And to summarize, this is a wonderful approach, non-extensile but highly versatile. to treat most of the anterior fractures, and in the experienced hands with the right instruments, we can treat some of the complex type of fractures. And identification and safe excision of the ilio-inguinal fascia remains the most important point. As I mentioned, you feel for the pulse, you don't feel in the cadavers, you feel for the pulse, mark with the cautery and cut the conjunct tendon only up to that. Don't go beyond that, because you don't need to do anything with the tendon covering the vessel. Then give attention to the important structures, and a meticulous closure is extremely important if you want to avoid any kind of post-op hernia. Just to show that this is a ABC fracture, again, you can fix from the and this approach, Ilio-Inguinal approach, and finally fix the posterior column with a lag screw from the brain of the pelvis. But see, in the case like this young lady, 13 years old, and this was a type 2 ABC fracture. This was in 2004, and today if this lady comes to me, I'll do an external approach, but I elected to do the dual approach. And you see, this was the exposure, and this is the immediate post-op X-ray. This is magnified view of the same. This is at the end of 3 weeks, and this is at the end of 6 months, and this is at the end of, this one is at the end of 6 years, and this is at the end of 10 years, and this is what you see, the Jude view, joint space is maintained, this congruous hip joint at the end of 17 years. See, this currently lives in Bangalore, and I just called her to find out about the hip joint. See, the hip is now narrowed down, there is evidence of secondary changes in the joint, and this is the Jude view, which is looking good, and this is her functional status. And you can imagine this is the fracture in 2004, and today she has got a hip joint, it's still functional and doing well. And when I asked for some pictures, she sent me the picture that she's dancing in the wedding, which she got married last December, and she's absolutely fine. So, approach well executed, even in complex fracture, will give you a good long-term activity. Thank you all. But if I have got a couple of minutes, there is always a confusion about the ilio-pectineal fascia. If the chairman gives me permission, I can just show another 2 minutes. I can show you. Can I?
Yes, sir. You can.
Okay. So this is a pelvis which I just while sitting with you, I thought I should show you. This is pelvis with this is you can say external oblique aponeurosis, the inguinal ligament, and you need to cut here. You need to make an incision over here. And when you do that incision right up to here, then and you retract the external oblique aponeurosis, you come inside the inguinal ligament, then you make your incision here on the conjunct tendon, and when you do that, on your lateral side you see this femoral artery. Okay, you feel for the pulsation. The moment you feel the pulsation, you don't cut beyond that. You just stay there, and because just below that you find this ilio-pectineal fascia. This fascia you'll find. I hope I am able to show. This is the fascia you'll find, and then you cut it from the top to the backwards. And once you cut, you go backwards, cutting towards the sacroiliac joint, and then towards the medial side. So this is how. See, this is a little bit of imagination in this, but I think if you follow the steps, you will not have any problem. And you need certain instruments. Dr. Lokesh has so beautiful special instruments for the stopper approach. You need this basic tool, the picator, then you need this Bata slam, you need the eccentric reduction forceps, and then you need this symmetric forceps for this thing, and you need a young blood reduction forceps for the difficult fractures. You need young blood reduction forceps, and of course the caliber you need if you are wanting to reduce the crest. So then you need some instruments for many other fractures, like templating, bone distractor, and all that. So with this, you really can execute a good Ilio-Inguinal approach. And when I was giving this talk, I was worried where to find the data, but anyway, I recovered all my whatever I had stored. And I would love to do this approach again rather than doing the STOPA, because this really is a wonderful approach. Thank you everybody for your patient hearing.
Thank you very much, sir. And now we come to the last of the basic approaches, that is the ilio-femoral approach. And I request the President-elect of AOPAS, Dr. Jose Papanchari, to please take over.
CP, can you stop sharing your slides? Because I'm unable to share because the other participant is sharing. Yeah.
Is it okay now?
Yeah, it's okay now.
Okay.
Good morning, friends. At the fag end of this webinar, we will discuss about the ilio-femoral approach. First of all, I would like to thank the Indian Orthopaedic Association and AOPAS for asking me to give this talk. I feel privileged and honored to do this. The ilio-femoral approach for fixation of the acetabular fracture is different from the other ilio-femoral approach, which is popularly known as Smith-Peterson approach. This is an approach for the hip joint. In our approach, we expose the inner aspect of the innerminate bone. In the Smith-Peterson, the exposure is on the outside of the innerminate bone. The patient is in the supine position. The incision is along the iliac crest up to the ASIS. There it goes downwards along the line of the sartorius muscle. The abdominal muscles, which usually overhang, are detached from the iliac crest and pushed medially. Then the iliacus muscle is elevated from the internal iliac fossa. Anteriorly, you can do the approach in two ways. Earlier, we used to detach the inguinal ligament and the sartorius from the ASIS, but these days, instead of that, we do an osteotomy of the ASIS with the attached sartorius and inguinal ligament. This is a much better way of doing this approach. To do that, you need to develop the interval between the tensor and the sartorius. You incise the fascia over the tensor, and that will take you to the interval. But proximally near its attachment to the ASIS, both these muscles have a common attachment, and the separation can be a bit difficult. Once you do the osteotomy and move the osteotomy fragment medially with this attached sartorius and the inguinal ligament, the straight head of rectus femoris is seen originating from the anterior inferior iliac spine. If you need to, you can do a tenotomy of that, and that will expose the ilio-pectineal eminence. You also will see the iliopsoas tendon there, and you may do a tenotomy of the iliopsoas if you need to. If the hip joint is to be opened, you can do a capsulotomy with around the acetabular rim after pushing the iliopsoas medially. But remember, do not devascularize the acetabular fragments, especially when there is combination of the acetabular fracture. The access of ilio-femoral is actually limited. To give you good access to the iliac crest, the internal iliac fossa, the anterior column is exposed up to the ilio-pectineal eminence. Posteriorly, you can reach the SI joint and also the posterior part of the pelvic brim. But you can feel the quadrilateral surface and the greater sciatic notch also. So you have palpatory access to the quadrilateral surface and greater sciatic notch. If you need to expose the outer surface of the ilium, you can release the abductor origin. To some extent, if you need to put only a clamp on the outer surface, and if your fracture needs exposure of the outer surface, then you can release the origin of the abductor muscle as much as possible, but you can never reach the posterior column or posterior wall by releasing the abductor muscles in this approach. I'll show a video now. This video was given to me by Dr. Ramesh Sen. I would like to thank him for his kind gesture. So supine position, The incision centered on the anterior superior spine, going proximally across the iliac crest and distally along the line of the sartorius muscle. The abdominal muscles, which usually overhang, are erased from the iliac crest and they can be pushed medially. So the muscles are pushed medially, and you can also elevate the iliacus from inside the ilium. Distally, the interval between the sartorius and the tensor is released. It is separated by dividing the fascia over the tensor. Proximally, as I said before, these two muscles take origin together from the ASIS, and the separation is a bit difficult. You need to release the anterior, maybe 2 centimeters of the tensor origin from the ASIS, so that the osteotomy of the ASIS can be done without damaging the tensor. That's the step you see now. The osteotomy size is about 2 centimeters long and 1 centimeter thick. Tree drilling is done before the osteotomy so that the reattachment is easier. Once the osteotomy is done, the osteotomized ASIS along with the attached sartorius and the Ilio-Inguinal ligament is pushed medially. That will protect the lateral cutaneous nerve of thigh. So the chance of injury to this nerve is less when we do the osteotomy. Then the fascia over the iliobacterial eminence is cleaned, and that's actually the distal extent of this approach. You can keep the iliopsoas flexed at this stage to relax keep the hip flexed to relax the iliopsoas. In the pelvic rim, you release all the fascial attachment. There will be bleeding from the nutrient foramen in the iliac fossa, which can be easily controlled by bone wax. After you have done the fracture fixation, you reattach the osteotomy of the ASIS, hold it with a clamp, and use screws through the pre-drilled holes. Make sure that the ASIS does not get splintered because it's a thin structure. Then the skin is closed in layers. So the drawbacks of the ilio-femoral approach, mainly the limited exposure. Because of the iliopsoas muscle, the exposure to the medial side is limited. That acts as a block. You can reach only up to the iliobacterial eminence in this approach. You may do an osteotomy of the iliopsoas, but it increases the risk of femoral nerve injury because the retractor can retract the nerve quite a bit once the protection of the tendon is not there. Unlike the other anterior approaches, here the risk of heterotropic ossification is present. The structures at risk are the femoral nerve and the lateral cutaneous nerve of thigh, but with the ASIS osteotomy, the injury to the lateral cutaneous nerve of the thigh is less. The indications is mainly indicated for the high fractures of the anterior column. You can also use it for the anterior with positive hemitransverse fracture when the anterior fracture goes more proximally. Again, useful for anterior column components of the T or transverse fracture if the anterior component is sufficiently high. But ideally, ilio-femoral approach is used for a single large anterior column fracture extending to the iliac crest. Some examples here: transverse fracture with more displacement in the anterior column. You can see that the posterior column is hardly displaced. Ilio-femoral approach and fixation with two plates. Another advantage of the ilio-femoral approach is that you can combine it with the Kocher-Langenbach approach in the same lateral position. Once you have completed the Kocher-Langenbach, you just tilt the patient 30 degrees posteriorly in the lateral position itself, and then carry on with the ilio-femoral approach. You don't have to put the patient on the supine position to do the ilio-femoral. So that's a great advantage, so that you don't have to re-drape the patient. The case here, both column fracture dealt with combined approaches, Kocher-Langenbach and ilio-femoral approaches, plates in the anterior and posterior columns. The ilio-femoral approach can also be combined with the AIP. When you do that, you can fix any type of anterior column or anterior wall fracture through this approach rather than using a Ilio-Inguinal approach. If your anterior column fracture extends to the superior pubic ramus, you add a final seal approach for that, and that will give you good approach, good exposure of the anterior column. You can avoid Ilio-Inguinal in this case. This is a high anterior column fracture, inviting actually to do a ilio-femoral approach, and ilio-femoral with SIS osteotomy, anatomically reduced and fixed. This is another case, anterior column fracture. You can reduce a fracture well through the ilio-femoral, but since you don't have access beyond the iliopectineal eminence, plate fixation is difficult. As the alternative way of fixation is using what's called in-out-in screws, described by Dr. Sen. You start the screws in the region of the anterior inferior spine, then come out of the bone to prevent penetration into the hip joint, then again re-enter the bone. This will give you good fixation, good compression, and good fixation. So this is an example of such a case. Compared with the ilio-inguinal approach, this is less dangerous. The reason is that you don't go anywhere near the inguinal canal, you don't open it. Also, you are far away from the femoral neurovascular bundles. The other advantage of ilio-femoral is that combination of ilio-inguinal with Kocher-Langenbach is a bit difficult, cumbersome, but combination of ilio-femoral with Kocher-Langenbach approach is easy. You can do that in the same lateral position. But as Dr. Das said, Ilio-Inguinal is a much more versatile, fantastic approach. So ilio-femoral is useful only for a limited indication, and the complications are less here. There is a modification of the ilio-femoral using an iliac crest osteotomy. We saw that you erase the abdominal muscle from the iliac crest in this approach usually, but instead of that, you can do a iliac crest osteotomy about 10 centimeter long and 2 centimeter thick with the attached abdominal muscles, sartorius and inguinal ligament, and put everything medially. This spares the abdominal muscle insertion, and the exposure is much more wide than the usual ilio-femoral, and you get an opportunity to work very close to the fracture. Like the usual ilio-femoral approach, this can be combined with the posterior approach also. To summarize, the femoral approach is a useful approach, but the exposure is limited, especially distally. You cannot go beyond the iliopectineal eminence as a drawback of this approach, but the complications are less, and the advantage is that this can be easily combined with the posterior approach. So useful approach for the right indication. Thank you very much for your kind attention.
Thank you very much, Dr. Papanchari. Dr. Ashok and Dr. Ajithkumar, do we have any questions coming in from the participants?
No questions.
Dr. Ajithkumar, do you have any questions or any suggestions related to any of the talks?
No questions.
In that case, I will request Dr. Ajithkumar to give the closing remarks. We are away on time.
I would like to extend my sincere thanks to all the viewers of this webinar. And I would like to thank Dr. Pradeep Kothadia, Dr. Ramesh Perumal, Dr. Sameer Agrawal, Dr. Lokesh V, Dr. C.P. Das, Dr. Jose Papanchari for their informative and elaborative talks on this acetabular fracture. And I would like to extend my sincere thanks to Dr. Naveen Thakkar, Dr. Ramesh Sen for their welcome speech, and to Dr. Pranav Shah for his nice moderation. Thank you.
Thank you, everybody. I think we can stop the recording now. Thank you.
Leave now.
Yeah. Thank you, everybody.
Thank you, everybody. Goodbye. Stay safe and take care. Stay safe and take care.
Thank you all, sir. Thank you.
Thank you. Thank you.